Something else. Okay, can you hear me now?
Yes.
Fantastic. Okay, sorry about that, guys. So we'll give us another minute. Just make sure whoever wants to log on is on, and we'll get started. All right. Really appreciate everyone jumping on. Hopefully, we'll have a great time, and we'll try and make this as interactive as possible. So there's a bunch of slides that we'll go through, and again, it'll be in the format of vignettes. So we'll give you a quick clinical scenario, kind of like the way how if a patient would present the triage. You visually assess them and see if you can come up with a diagnosis. Sound fair?
Yeah.
Okay. All right. So why don't we get started? Thanks so much for my presenter working. All right. Okay. So case one. So we have a 31-year-old female who presents with complaints of having tooth pain and a swollen neck. And this is what she looks like. Anyone want to venture a guess in terms of what's going on here?
Ludwig's.
Ludwig's.
Fantastic. Ludwig's angina. Perfect. So, and you can see the Ludwig's angina kind of evidenced here by this brawny, really red, kind of deep skin changes. So what is Ludwig's angina? So in order to get into the Ludwig's angina, it's important that we talk a little bit about anatomy. So Ludwig's angina specifically is a deep space infection that's located in the submandibular space. And the submandibular space is divided by the mylohyoid muscle. It's a sublingual space superiorly, and then the submandibular space inferiorly. What's the cause of Ludwig's angina? In greater than 90% of the case, it's dental or dentogenic in source. But we have seen etiologies from other reasons resulting in Ludwig's. Trauma, tongue piercings. We actually saw a couple of these cases when I was working on my last site. Sialadenitis, tumors can occasionally do it, or other deep space parapharyngeal infections. So just to review a little bit of anatomy. So kind of this is straight out of Netter's. So this is superior, inferior, anterior, and posterior. So what we're looking at is specifically an infection in this area right over here, right underneath the tongue. And it's a deep space infection that essentially lifts the tongue up and pushes it forward, which makes it a true airway emergency. It completely occludes both the oropharynx as well as the nasopharynx. And just a little bit of a review of anatomy. So at the level of the cords, the vocal cords is your glottis. Anything above it is supraglottic. Anything below it is infraglottic. Trachea is anterior, and the esophagus is posterior. All right. So the segment has Ludwig's angina. They've got to get back to versus fiber optic. It's really dependent on the operator. This is not one of those things where you get the medical do this kind of blind or this is a terrible situation. In addition, once the patient is intubated and you've got good airway control, you want to treat the infection. And again, this is a polymicrobial infection, specifically stuff that's located in the mouth. So you're going to have a lot of anaerobic bacteria, you're going to have a lot of fusiform bacteria, and a lot of strep and staph. So generally, you want to go broad spectrum, but third-generation cephalosporin plus clindamycin to cover against the anaerobes in order to take care of the infection. In general, there's no indication to treat these patients with steroids. There's no benefit to decreasing airway edema or decreasing the edema around the infection. Really, it's airway control, broad-spectrum antibiotics, and these patients have to go up to the OR. The definitive treatment is going to be surgery. But prior to antibiotics, the mortality was as high as 50%. The mortality now with antibiotics and surgery is still not 0%. It's still pretty significant, about 8% mortality. This is what Ludwig's angina looks like on CT scan. So you're looking at the axial cuts over here on the left, and then the sagittal cuts on the right. So with this area, this kind of rim-enhancing fluid plus air is where that infection is, and this is right in the submandibular space. As you can tell, it's almost completely occluding the area where the vocal cords are. And this is it just on the sagittal view. And just imagine, just looking at this over here, you're going in to intubate the patient. All this infection is going to be potentially occluding your view of the supraglottic and then of the glottis entirely. That's why really early intubation is super, super critical. This is what the patient looks like with widespread debridement. So what you're seeing here are red rubber tubing, and this patient could not be intubated orally. Wound up having to do this as a tracheostomy, as an emergency trach procedure, which was a life-saving procedure in this particular case. All right. Any questions about Ludwig's? All right. We'll move on to the next case. We've got a 75-year-old white male who presents with 5 days of rash and pain to the forehead. This is what he looks like. You want to venture a guess of what's going on? Okay. Since there's no takers. So this is...
Oh, sorry, I was on mute. Yes.
Okay. Anything specific about this herpes zoster in this gentleman?
That it's near his eye, so you need to be worried about the time.
So yeah, so you're worried about zoster, specifically in the V1 distribution of the trigeminal nerve. But take a look at this. He's got a little lesion on his nose, right? Does anyone know what that's called?
Hutchinson sign?
Excellent. Hutchinson sign. Fantastic. So herpes zoster ophthalmicus specifically is caused by varicella zoster. And reactivation in the V1 distribution is what produces a typical dermatomal kind of finding, the skin finding. It's possible to get widespread dissemination in people that are immunocompromised. We see zoster obviously in immunocompetent individuals, but if you see it involving 2 or more dermatomes, you have to be concerned that there's underlying immunocompromise. Specifically, if it attacks the anterior horn cells of the spinal cord, you can get muscular weakness similar to MS, leading to diaphragmatic paralysis, colonic pseudo-obstruction, and if it happens in the posterior aspect of the spinal cord, you can get a Guillain-Barré-like syndrome, which is that ascending paralysis, as well as a transverse myelitis. There are 3 phases of zoster infection, not just of the face, but anywhere that it winds up erupting. You've got the pre-eruptive phase. And essentially, this is 48 to 72 hours before you start to see the lesion. And you start to get this kind of weird pain sensation in a particular location, and you might get dysesthesias, where a patient may feel cold if you're touching them with something hot, hot if you're touching them with something cold. And it really, there's nothing there. They may come in for kind of really vague complaints, saying, like, I get out of the ER, there's nothing wrong with you. They show up a little bit later, and all of a sudden, you're in the eruptive phase. And now the first step of the eruptive phase is where you get these macules. And what macules typically are just red spots. The red spots turn into vesicles, which are clear, fluid-filled blisters, which then become ruptured vesicles, which become very painful, ulcers, and then ultimately the healing phase, which is when you have a crusted lesion. This process generally takes about 2 weeks to be completed until you get a crusted lesion. Of note, it's not considered a healed lesion until the lesions are crusted. So the person is still considered very, very much infectious until the lesions are crusted over. And the reason why that's important is that if you have this patient sitting in internal triage, it's going to be really important to kind of get them to a private room away from other people. The varicella zoster, the herpes infection specifically, is considered a torch infection. And the torch infection are toxoplasmosis, rubella, cytomegalovirus, and herpes, which can cause birth defects in women that are pregnant or could be potentially pregnant. So it's important to put these patients in isolation, and also when you're discharging them, to let them know that they really should stay away from people that, again, may be pregnant or are pregnant. The post-eruptive phase is sometimes what we'll see patients coming back to the ER for. Postherpetic neuralgia is pain that lasts in that same distribution where they had the prior zoster for greater than 30 days. And it's the most frequent complication that can occur as a result of having infection with zoster. And it occurs in a pretty large percentage of individuals, 9 to 45% of all cases of zoster. And it tends to have a higher incidence in patients that are elderly and male. Specifically, with regard to this patient, it looks like he has herpes zoster ophthalmicus, which is reactivation of varicella zoster, specifically in the V1 distribution of the facial nerve, of the trigeminal nerve. And what this gentleman had was specifically, somebody yelled it out, was the Hutchinson sign, which is a lesion that you see on the tip of the nose. And that increases the likelihood of ocular ocular and 26% versus 34%. I would say, like you were saying, Lauren, if you see that lesion in V1 or even V2, I would have a really, really low threshold for fluorescein staining these individuals. And so what are you going to see if you fluorescein stain these individuals that have potential ocular involvement? So you'll see pseudodendrites. And what pseudodendrites are, they look like dendrites, but they wipe off. The reality is that you're going to treat it almost essentially equivalent. You're going to wind up getting ophthalmology involved because there's significant mortality that's involved if a patient has ocular involvement, as it can result in ocular loss and really globe rupture. So complications of the zoster in general can develop some postherpetic neuralgia. Of the eye can develop corneal anesthesia or hypoesthesia or secondary bacterial infection. The treatment, the only really beneficial proven treatment is antiviral. Specifically, we tend to give out valcyclovir instead of acyclovir just because of ease of dosing. And it's been shown to reduce the viral shedding and accelerated resolution of symptoms. But it's really only proven to be of benefit within 48 to 72 hours. That being said, if I see somebody with zoster, I tend to just put them on it. It has a really wide margin of safety. There's really not much of a downside to starting patients on Valtrex. And if it decreases the likelihood of viral shedding, it potentially decreases the likelihood of postherpetic neuralgia, I'm fine with it, and I'll start pretty much everyone on Valtrex. The other modality of therapy is corticosteroids. It's controversial at best as to whether or not corticosteroids help at all in patients with any form of zoster. There are two studies that looked at steroids plus acyclovir, and there was kind of a mixed bag of results. It's really only indicated in patients with moderate to severe pain, or if their severe central nervous systems or paralysis exist. The use of corticosteroids in isolation is absolutely not recommended, as it's theorized to increase the likelihood of viral replication. All right. Next case. We've got a 24-year-old man who presents with pain to the nose after being hit in the head with a soccer ball. Take a look at him, and he's got the following. Anyone want to venture a guess in terms of what we're seeing?
Bulging terminus.
Septal hematoma.
Fantastic. Good. Septal hematoma. So why does the septal hematoma occur? So the nasal septum is really, really thin. You've got thin layer of nasal cartilage. It's about 4 millimeters thick. And adjacent to the septal cartilage, you've got the perichondrium. If somebody has direct trauma to the face or to the nose, specifically, what can occur is that you'll accumulate blood in this area right over here, causing the perichondrium to lift off of the nasal septum, and this leads to a pressure necrosis of the nasal septum. It's essentially, it's really uncommon, but it's one of these things that it behooves us to look at. It takes an extra second to take a light and just take a look up their nose to make sure that there's not a septal hematoma. The big thing is that if they have a septal hematoma on one side, don't stop there. Look on the other side. They may have bilateral septal hematomas. So, again, if you have a septal hematoma, it can lead to accumulation and develop a pressure necrosis of the nasal septum, which can lead to a septal perforation and lead to a saddle nose deformity. It looks like part of their nose is collapsed down. And that's, one of the cosmetic deficits that can occur as a result of having a septal hematoma. The other more serious complications are to develop an abscess in that area, because again, you've got a lot of bacteria. The same bacteria that live in the mouth also live in the nose, and you can develop. Oops, sorry about that, guys. No, I don't want to do that. All right. So the other thing that can develop is meningitis, encephalitis, and cavernous sinus thrombosis. The reason why specifically meningitis and encephalitis are particular concerns is that the nose exists within what's called the danger zone of the face. The veins that drain back from the face, kind of in the same area adjacent to the nose, are valveless and allow infections to travel rapidly back into the brain. So you can have some really, really deep space, terrible infections that can occur as a result of bad infections in this danger zone of the face. So again, just make sure to examine bilateral nostrils in all patients with facial trauma. Takes an extra second to do. And if they have a septal hematoma on one side, take a look on the other side. The treatment for this is incision and drainage in order to relieve the pressure off of that area. All right. Case number 4. We've got a 70-year-old Asian woman who presents with a headache, nausea, and eye pain while she was watching a movie at one of the local theaters. Obviously, this was pre-COVID because now no theaters are open. All right. Anyone want to venture a guess in terms of what's going on here? All right. So what this is acute angle closure glaucoma. And it's evidenced here by a fixed mid-pupil, kind of steamy, hazy cornea. And so in order to understand what acute angle closure glaucoma is, it's important to look at the anatomy. And the anatomy, we all get scared about kind of examining patients with eye complaints because it's kind of in the ether for us. We don't do a whole bunch of eye complaints in the ED. But then again, the ophthalmologist spent 4 years studying the eye. We can figure it out in a couple of minutes, right? So this all really goes back to anatomy. This is the anterior portion of the eye. This is the posterior portion of the eye. And so for the purpose of the discussion, we're going to concentrate just really on the anterior portion of the eye. So with regards to acute angle closure glaucoma, what we're looking at is where aqueous humor is being produced. So this is a ciliary body, and it's located on both the superior and inferior aspect of the globe. Aqueous humor is produced in the ciliary body. It then goes from the posterior chamber, which is over here. This is the lens. The aqueous humor then transits anterior to the lens, goes out through the pupil, and then gets reabsorbed right over here at the angle of Schlemm. At the angle over here, which is called the canal of Schlemm. So in most people, this process happens unimpeded whatsoever. In individuals with acute angle closure glaucoma, this angle of Schlemm gets occluded for a multitude of different reasons. Some of them could be congenital. Aqueous humor continues to be produced, but now it can't leave. So it continues to build up pressure higher and higher over here in the anterior and posterior chambers, which can ultimately lead to visual loss. So again, aqueous humor being produced in the ciliary body anterior chamber, goes through the pupil, and then ultimately drains into the vascular system through the canal of Schlemm. So acute angle closure glaucoma is defined by the presence of two of the following symptoms. So ocular pain, nausea and vomiting, or a history of intermittent blurring of vision with halos. Normal ocular pressure is usually closer to 10 millimeters of mercury. Patients with acute angle closure glaucoma, or when you start to get suspicious of it, is when they have an intraocular pressure greater than 21, but really greater than 50 millimeters of mercury. You'll see an association with a conjunctival injection, corneal epithelial edema. You'll see a mid-dilated, non-reactive pupil. And for those of you that are really good looking with the slit lamp, you'll see a shallow anterior chamber. Then result, again, like we had mentioned before, is just continued sustained production of aqueous humor, which is unable to go from the posterior to the anterior chamber, just continue to build higher and higher pressures in the eye, ultimately resulting in retinal damage and visual loss. So some of the risk factors for acute angle closure are older age, female, specifically women of Asian descent, a known congenital shallow anterior angle, excessive sympathetic tone, a thin iris, or a darkened environment, like which happened with our patient that was an elderly Asian woman who was in a movie theater. But essentially, any condition which causes the iris to get heaped up and prevent normal drainage of the aqueous through that canal of Schlemm is what's going to wind up leading to an increase in pressure. So it is super important for any patient that comes in with complaints of headache and eye pain, actually look at their eyes. Pry open the eye, take a look at the pupil. They may be photophobic, but it is really super important to take a look and see what's going on there. Tono pen, or whatever other modality you're using in order to check pressures. As often is the case, the tono pen is either missing or not working. So luckily, we've got thumbs. You can use your thumb to get a rough estimate with regards to pressure. Patient with acute angle closure glaucoma, specifically with greater than 50 millimeters of mercury of pressure, their eyes can be firm like a rock. You can compare it to the other eye, especially if they have another eye. You'll feel that the right eye, say if the angle closure glaucoma is on the left eye, feel the right eye. It'll feel soft and squishy. The left eye will feel really hard and firm. It's just kind of a simple means. And it should be concerning enough in order to get your local friendly ophthalmologist in the door saying, hey, I don't have the ability to check pressures, but one eye is hard as a rock. How do you treat these patients? Well, lie them flat. One of the reasons why that works is that it causes the iris to bunch away from the lens and open up that angle and potentially allow drainage through the canal of Schlemm. If that doesn't work, take care of their pain. Start them on beta blockers, specifically timolol, which decreases the production of aqueous humor. Steroids, which reduces inflammation. Prednisolone, which you're putting one drop every 15 minutes. starting them on mannitol in conjunction with an ophthalmologist because they may develop rebound. And last but not least, is starting them on a topical miotic, pilocarpine, in order to cause the iris to back away from the pupil. And this won't work unless this is the order that I put this in is specific in terms of the therapy that should happen. You can't use a miotic unless the pressure is going to be less than 40 millimeters of mercury. So you want to start with these things first and then slowly work your way down the list. All right. Next vignette. 53-year-old female calls EMS for a headache and blurry vision. Lauren, I'm going to call you out on this one because we had something similar to this.
Oh, 6 nerve palsy?
So close. This is a cranial nerve 3 palsy.
Oh,
But yeah, good. Well, it has to be, if not that one, then it has to be the other one. So why is it so important to know about a cranial nerve 3 palsy? And I'll go back to this for a second. So the reason why this is a cranial nerve 3 and not a 6 is because you see that the eye is locked over here by unopposed action of the lateral rectus. The medial rectus muscle is not working whatsoever, and that's why this eye on the right is in the midline. The one on the left is being completely pulled laterally. The reason why it's important to be able to differentiate a 6th cranial nerve from a 3rd cranial nerve goes back to anatomy. The 3rd cranial nerve starts in the brainstem, goes through the subarachnoid space, goes through the cavernous sinus, and then ultimately terminates in the orbit after coming out of the superior orbital ridge. Its function contains both voluntary muscle fibers as well as parasympathetic control. It's responsible for the vast majority of extraocular muscles, including pupillary constriction, as well as raising the eyebrow. And again, it's a dual innervation to the levator palpebrae superioris. It's cranial nerve 3 and cranial nerve number 6. Typically, the eye will be down and out, which does not constrict or accommodate, which allows you to differentiate this from a cranial nerve 6. In addition, you might have associated ptosis. The reason why the anatomy is important is because if there's a suspected cranial nerve 3 palsy, there may be a PCA aneurysm, there could be uncal herniation, neoplasms, inflammatory conditions like multiple sclerosis or Devic syndrome. There could be trauma, again, resulting in increased cranial pressure. There could be something going on in the cavernous sinus, including both neoplasm and thrombosis, or they could have a carotid cavernous fistula. All really, really bad things. So if you see a cranial nerve 3 palsy, definitely make sure that you get imaging, potentially including MRA to get a better look to rule out the possibility for an aneurysm. CT angio is not bad. MRA is significantly better, however. It is possible to have isolated cranial nerve 3 deficits affecting primarily the extraocular muscles and really the pupil, and that can happen usually in patients that have microvascular disease, specifically a combination of diabetes and hypertension. It usually presents as pain, but if there's any question whatsoever, get neurology, get ophthalmology involved. Okay. Next case, we've got a 20-year-old wrestler presents with ear pain. What do we got? Anyone want to venture a guess what we got over here? Okay. It's a auricular hematoma. So auricular hematoma kind of is similar to a septal hematoma. It's when you've got blood accumulating in the space adjacent to cartilage. It causes the auricular perichondrium to separate from the underlying cartilage, and you've got the blood vessels that tear and start to accumulate blood in that potential space. Blood, when it's adjacent to the cartilage, stimulates new cartilage deposition, and then they result ultimately with cauliflower ear. And this is what it looks like if a auricular hematoma is not promptly drained. The recommendation used to be needle aspiration, but timing is really dependent on when the patient presents to the ED. So if it's been greater than 7 days, don't touch it. You're not going to be able to do anything. Patient needs referral to plastics or TNT. If it's less than 7 days, the recommendation is to do IND, not to do a needle aspiration, simply because the hematoma tends to reaccumulate. The important thing is that if you've drained a fair amount of blood from that area, it's important to put on a tight and occlusive pressure dressing. Otherwise, if you just put simple, really non-compressive dressing, maybe a little bit of Curlex here and there, the hematoma is going to wind up reaccumulating. Okay.
Can I ask a question?
Absolutely.
For the septal hematoma, is it a needle aspiration?
So you can, not really needle aspiration because it may get a little bit tough. If you take an 11 blade scalpel and just make a small nick, that's more than enough that you need.
Okay. Thanks.
And the only reason why is that with a needle, sometimes it's difficult to control how deep you go with a needle, especially like with a peritonsillar abscess. That's why with a scalpel you get a little bit better control. And again, all you need to do is a quick stab incision, and you'll get the blood out of that potential space.
And then, do you have to put pressure on that as well?
No, you don't. So it's only really for the auricular hematoma, just because of in the nasal septum. It's hard to put pressure on that area. Just a little bit of digital pressure will wind up resolving the amount of accumulated blood, but it's really more of a concern specifically in the auricular cartilage that will wind up reaccumulating blood to a higher extent than you will with a septal hematoma.
Okay, thank you.
No worries. Good question. So now we have an 18-year-old woman. She presents with ear pain and fever. You examine her and you see a tender erythematous bulge posterior to the ear. And you see this on physical exam. Anyone want to venture a guess what we're seeing?
Mastoiditis?
Fantastic. Yeah, exactly. Mastoiditis. So the mastoid bone is directly contiguous and is an extension of the middle ear cleft. Mastoiditis is really the result of either poorly treated or not untreated otitis media. If otitis externa and otitis media is allowed to continue, you'll result in erosion of the medial wall, which can result again in cavernous sinus thrombosis, cranial nerve 7 palsy because it goes right in that area, meningitis, and brain abscess. The treatment for mastoiditis is going to be similar exactly to what you use to treat acute otitis media. Strep pneumo being the most common organism. And the risk factors is likely multifactorial. You may have just an invasive species of strep pneumo versus the patient may have some abnormal anatomy. So it can generally narrow mastoid antrum, not allowing it to drain properly, and it'll lead to accumulation of bacteria, specifically in the case of otitis media. These patients should be treated with broad-spectrum antibiotics, specifically semisynthetic penicillins, Augmentin, or if they have an IV line, then you should be giving them third-generation cephalosporin like ceftazidime or ceftriaxone, or vancomycin in combination with something that'll cover gram-negatives. You should be getting a CT scan on these patients. And admission, it really depends on whether the patient's reliable, their comorbid conditions, and whether or not they can get timely follow-up with ENT. So if they can get timely follow-up, they should be admitted because these are patients that are going to get much, much worse. And if things don't improve after just conservative treatment with antibiotics, these patients may need surgery in refractory cases. All right. 20-year-old male presents with eye pain and fever after being scratched by his cat's claw 2 days ago. What do we got? Okay, so, well, we have an infection around the eye, right? So this actually, in this particular case, this is post-septal cellulitis. This is what the patient's CAT scan had demonstrated. So this is the right eye. This is the left eye on CT. This is anterior. This is posterior. And what we see is an accumulation of fluid posterior to the orbit. And also, if you take a look, imagine that this is the line in terms of where the cornea is. There's proptosis pushing this eye forward. There's infection, and then there's edema as well, which is causing the proptosis. Going back to anatomy, and we won't focus on all this stuff, the most important thing to remember to be able to differentiate preseptal from postseptal cellulitis based on anatomy alone is this part over here, the orbital septum. The orbital septum is what separates a preseptal from a postseptal cellulitis. That orbital septum is a fascial layer which extends vertically from the periosteum of the orbital rim to the inferior border of the tarsal plate in the lower eyelid. And orbital cellulitis is just specifically an infection posterior, deeper to the septum. It's usually as a result, postseptal cellulitis is usually an extension from an infection from the periorbital structure. Usually ethmoid sinusitis could do this, or you could have direct inoculation, in this case, from trauma or surgery. In addition, patients that are immunocompromised can develop a postseptal cellulitis from bacteremia. Again, veins in this area, the danger zone of the face, are valvulus and allow retrograde and anterograde flow. So it's bidirectional flow. Presentation is pain, fever, and chemosis. And the way to separate a preseptal from a postseptal cellulitis is if the patient has proptosis, and specifically if they have painful extraocular movements. These patients need CT scan with contrast, broad-spectrum antibiotics, and if you have postseptal cellulitis, these patients get admitted. Preseptal can be discharged home with close follow-up. Postseptal universally has to come in. Complications might have visual loss because of just continued traction on the orbital nerve. You can develop cavernous sinus thrombosis, and again, because these are valveless veins, they can result in meningitis, abscess, and then osteomyelitis of the bones of the face. All right. Now, this is not an uncommon presentation. We've got a 7-year-old boy comes in by mom for evaluation of a bump next to the eye. Anyone want to guess what this is?
Blocked lacrimal duct.
It's disgusting. Yeah, right. Yeah, it's a blocked lacrimal duct. So what this is called dacrocystitis. So normal eye anatomy is that tears are produced up in this area over here. The tears that are produced on the lateral aspect of the eye ultimately diffuse down, and then you've got the inferior and superior canaliculi on the medial aspect of the eye. The inferior canaliculi is what drains into the nose. This is also the reason if you cry, and I've never cried before in my life, so I wouldn't have experience with this. If you cry, the tears go directly into your nose because you essentially overwhelm the body's ability to drain the tears. So that's why they tend to overflow out. So if the inferior canalicular system is blocked, the tears accumulate, and you'll see these kids showing up, or adults, with a bunch of chemosis, and then also you'll see tears kind of coming over this edge. This looks a lot worse than it is. The microbiology is usually nasal and skin flora, and in most cases, overwhelming majority are self-limited. There's no antibiotics that are recommended at all for these, unless it's complicated. The vast majority of patients will do fine with just warm compresses, just in order to move the kind of gunk that they have in that lacrimal duct down, and this will resolve on its own. Cases that are more complicated may require nasal probing of that lacrimal duct, again, not done by us, done by ophthalmology. Or if the patient has multiple recurrent episodes of this, consider getting imaging. They may have a malignancy in that area that's causing chronic compression of that lacrimal gland, which is causing that obstruction and that recurrent episode of dacrocystitis. All right. 25-year-old woman, she comes to the ER screaming. States that this all started when she was trying to fall asleep and she was yawning. Any guess on what's going on here?
Jaw dislocation.
Fantastic, exactly. Yeah, this is a TMJ dislocation. And this happened to me. I was a brand new attending. I was working, and all of a sudden I heard this blood-curdling scream coming from triage. Yeah, it was a woman that came in with a TMJ dislocation. It hurts like hell. So TMJ dislocations occur when the mandibular condyle disarticulates from the articular groove in the temporal bone. This is a diaphyseal joint, and it's relatively difficult to dislocate because there's a lot of muscular and ligamentous attachment. That being said, if somebody has had issues before in the past, say with grinding their teeth at night or having issues with clicking in their jaw, it increases the likelihood of them having issues with that joint and also increasing the likelihood of them having subsequent dislocation. The most common locations that dislocations can occur are going to be anterior. Superior dislocations can occur posterior and lateral. Lateral dislocations tend to occur in conjunction usually with trauma, and you'll usually see an associated mandibular fracture with that. If it's anterior, that's going to occur in probably 90 to 95% of all your cases. These patients generally present, the ones with anterior dislocations, with an inability to close their jaw, and the treatment really is sedate them and push it back down. This is kind of a risky procedure to do if you haven't done it before. You want to wrap your thumbs in a bunch of Curlex, or use the plastic kind of Vacutainer guides to wrap around your thumbs. Because if you haven't done this before and you go to reduce these patients, that jaw will snap shut on your fingers, and the last thing you want to do is lose the tops of your fingers as a result of the reduction. All right, case 11. We've got a 48-year-old woman with no past medical history who presents with the following midline neck mass. She states that it's been there for a long time, as long as she can remember. But now she comes to the ER, of course, because she wants us to take care of it and get rid of it for her. So this is the midline mass. Anyone want to guess what's going on here? This one's a little bit tougher. So this midline mass could be a lot of different things, but the fact that it's midline tells you that it's probably benign. And what this is a thyroglossal duct cyst. It is the most common form of congenital neck cyst, and usually occurs as a result of the branchial cleft that fails to involute and leaves this kind of midline cystic structure. The thing that distinguishes this from the thyroid or from other more malignant causes is that A, it's midline, it's non-tender, and because it's fixed to the hyoid bone, it moves up and down when the patient moves their tongue back and forth. It rarely ever gets infected. If there's redness around it, consider starting these patients on some Augmentin or some kind of equivalent antibiotics. And if there's any concern that there's airway involvement, feel free to get some imaging. The definitive treatment is going to be to refer these patients to ENT for excision and closure of that tract. And it's not a bad idea to send a TSH, as these thyroglossal duct cysts sometimes do contain ectopically located thyroid tissues. But that's usually done by the ENT. But just something to keep in mind if somebody happens to show up and they're complaining of this midline lesion. Right, case 12. We've got a 58-year-old man who presents with a 2-week history of progressive dyspnea on exertion, neck swelling, decreased appetite, and fatigue. And he lets you know, by the way, he quit smoking on the way to the hospital today. This is what it looks like. Anyone want to venture a guess? Okay, so just keep in mind, let's take a look. So this, see the swelling? The varicose veins? So this is SVC syndrome. And SVC syndrome stands for superior vena cava syndrome. And essentially what it is a backup of blood due to compression of the SVC. So the SVC is located directly superior to the entrance of the blood vessels into the right atrium. SVC is very, very pliable. It's located in the middle mediastinum. And compression on this area causes blood to flow back through the collateral. Like you see on this gentleman over here, his whole upper chest and upper extremities, they're all getting swollen because of compression by this mass that he has in the mediastinum, and causing the blood to back up within the SVC. The SVC carries a third of the body circulating volume, and again, it's pliable and easily compressible. The normal pressure in SVC is around 5 millimeters of mercury. And again, compression leads to retrograde flow into the collateral vessels. The vast majority of the etiology is unfortunate. It's carcinoma. And it's depending on where the carcinoma is located, will kind of tell you in terms of the etiology. So really the bad ones are teratoma, thymoma, really terrible lymphomas, and some bronchogenic carcinomas. There are certain infections that can cause compression of the SVC, specifically TB and syphilis, or if the patient has a central venous line that's become occluded, that can also lead to SVC syndrome. Symptoms being limb and facial edema, headache, confusion, and dyspnea. And the confusion occurs because, again, those veins are draining from the jugular vein. And if there's an increase in back pressure to the head, that can lead to the headache and to the confusion. Treatment is unfortunately directed at the underlying condition. If so, the patient has carcinoma, which is very, very common in this condition, this generally indicates a very, very poor prognosis when you see it on the patient. Their all-cause mortality is greater than 90% at 6 months. So if you see it, it's pretty unfortunate. And really the therapy is really geared towards more debulking of the mass there. Radiotherapy, stents, and then tumor debulking. Okay. EMS 13. EMS brings in a restrained driver. States that EMS tells us was involved in a frontal collision on the Garden State Parkway a short while before arriving to the ED. And you see this on the patient when you get him undressed. What do we call this sign?
Seatbelt sign.
Fantastic. Yeah, you see a seatbelt sign. So you see the belt coming across on the chest. In addition, you see some abrasions on the abdomen and some abrasions here on the left hip and left shoulder. So why is it important to know about the seatbelt sign? So today's modern seatbelts, with specifically the 3-point seatbelts, when worn correctly, has significantly reduced down the morbidity and mortality as a result of motor vehicle collisions. You don't see seatbelt sign that often, right? It only occurs in about 20% of motor vehicle collisions. The presence of seeing the seatbelt sign increases the likelihood of underlying thoracic injuries fourfold and abdominal injuries by eightfold. So the fact that you see it means that you should really drop your threshold in terms of what's going on with these patients and have a lot more liberal use of imaging. If you see the abrasion over the neck, the likelihood increases dramatically of having carotid artery injury, laryngeal injury, or a C-spine injury. If it's over the chest, fractures of the sternum, ribs, clavicles, or aorta, specifically a dissection, or having a pericardial effusion or myocardial contusion. If you see it along the abdomen, it could result in mesenteric injury, bowel perforation, hematoma, chance fracture, liver lax, splenic lax, renal artery dissection. I mean, the list goes on and on. The bottom line is that if you see a seatbelt sign, that should really clue you in that this patient underwent a significant deceleration injury, and we should be doing more imaging, not less imaging. Again, thorough exam, liberal imaging, frequent reassessment are the cardinal points for another. All right, next case. We got a 50-year-old man. He was curling 100-pound dumbbells at the gym. He's trying to get in shape to be a youth cast member on the Jersey Shore. I don't think it's Ronnie. But anyway, the patient heard a pop, and then he felt a pain in his right arm. And you see this on the exam. Anyone know what this sign is called? Or know what condition is going on here?
Ruptured bicep.
Bicep tendon rupture and Popeye sign.
Fantastic. Spot on. Exactly. So this is the Popeye sign, where you see the muscle kind of bunched up on the right over here, and that's what it looks like over here. And again, Popeye sign. And so this is a ruptured biceps tendon. So going back to a little bit of anatomy, the proximal biceps has two heads which attach proximally about the scapula. Distal biceps goes down to the radial tuberosity. The biceps is normally used in order to cause forearm flexion and supination. And the most common location of injury is at the proximal attachment, where they rip out that proximal attachment, and that leads to the heaping up of the biceps muscle. Most patients that come in describe a pop and then loss of strength in the affected arm. So repetitive microtrauma. So somebody that's been weightlifting a lot develops these repetitive kind of small tears in the muscle that eventually culminate in a large tear. People that use steroids, or the ones that just decide that they're going to start bulking up real quick in order to get ready for a summer season. It's not uncommon to see in these individuals. All right. So what do you do for these patients? Get an X-ray just to make sure that there's no bony avulsion fracture. You're going to sling them, provide them with NSAIDs, and ultimately refer them out for orthopedics. They're going to need definitive surgical repair. All right. Next case. We've got a 37-year-old man presents with pain to his left hand after getting it scraped along a brick wall. And you see this. Anyone have an idea what's going on here? So one of the things I should mention, this patient in this case is also left-hand dominant. And also, this is a very, very typical board question in emergency medicine. This is a fight until proven otherwise. This is a person that probably punched somebody in the mouth and resulted in a little bit of an abrasion / laceration of the metacarpal, right over the metacarpal. The reason why this comes up as a board question is because they want us in the ER to take care of these patients by giving them antibiotics. Even if they tell you, I just scraped it on a wall, you always want to treat patients that have any type of injury overlying the surface of the metacarpal as a fight bite until proven otherwise. Yeah, so all wounds at the MCP joint, especially on the dominant hand, are fight bites until proven otherwise. The infections tend to be polymicrobial, especially when it's a fight bite, because of all the nasty bacteria that humans have in their mouth. And you want an antibiotic that takes care of staph, strep, Eichinella corrodens, and fusiform bacteria, as well as the anaerobes. Complications. Because this is along the metacarpal, along the extensor surface, the tendons get rapidly involved and can result in a rapidly progressive infection. If the patient's infection is on their dominant hand, they can have significant loss of function. Septic arthritis, flexor tendinosynovitis can occasionally occur if there's widespread infection and may occasionally result in amputation. So really, really low threshold to give these patients antibiotics if you see a scrape or a wound overlying the metacarpal surface. All right. Management being, again, irrigation, they're testing their tendon strength, the breed injury if there's a lot of contamination, getting an X-ray to make sure that there's no foreign body in there like a tooth, giving these patients antibiotics, splitting and elevating them, and then either sending them for a hand follow-up, or if they're showing up with a badly disseminated infection, admitting these patients, especially if they have any of the Canavel signs indicating that they have flexor tendinosynovitis. All right. Case 16. We've got a 42-year-old dental assistant who presents with a painful and swollen finger. Anyone what's going on? Guess what's going on?
Herpetic Whitlow.
Fantastic. Herpetic Whitlow. And what you're seeing here kind of looks like purulence, right? But these are just kind of cloudy vesicles. So what we're seeing is exactly herpetic Whitlow, and this could occur because of either primary or recurrent HSV lesion. HSV, one we tend to see in kids who stick their fingers in their mouth, or you'll see it in dental assistants, specifically who are exposed to oral secretion. You can see HSV2 in adults due to digital genital contact, and it could be confused with a paronychia. Clear vesicles could be seen early. They coalesce and then appear purulent, and somebody may be tempted to either needle aspirate it or to take a scalpel to it. But there's no purulence there. It actually just contains necrotic epithelial cells. Symptoms are a painful and red distal digit. We may have reactive axillary lymphadenopathy. And the treatment is local wound care, control their pain. You can prescribe topical acyclovir, which decreases duration of symptoms. You can consider starting these patients on antivirals if within 48 to 72 hours. And the important takeaway with this is do not IND these patients. INDing of these wounds will result in widespread dissemination of herpes zoster, of HSV, so definitely do not IND it. Okay, case 17. EMS is called for a 45-year-old woman with no medical history who developed the rash 2 days earlier. It first appeared on her legs and buttocks, and then it spread to involve her ears and cheeks. She denies any fevers, travel histories, or sick contacts. And this is what she had. This was actually my patient a couple of years ago. Anyone want to venture and guess what's going on?
Bacterial meningitis.
And that's an excellent, excellent guess. And so the nurse that was triaging this patient was absolutely concerned that this patient had bacterial meningitis because she had these lesions on her lower extremities, which we typically associate with meningococcus, this type of rash, this purpuric type rash that occurs with meningococcus. And the nurse did absolutely the right thing by putting the patient in isolation. Turns out, however, it wasn't meningitis. And the only reason why I knew this is because I had seen a couple of cases of this before when I was working in the Bronx. This is what the patient's face had looked like. Pretty disgusting stuff. Actually, what she had was cocaine levamisole toxicity. She was a bus driver that happened to was clean for a number of years and then started using cocaine again. So levamisole specifically is the part that causes that necrotic endarteritis obliterans. So the DEA estimates that 75% of cocaine coming to the U.S. is actually adulterated with levamisole. So what is it? It's an anti-helminth. It has the same crystalline kind of looking appearance like cocaine. And it's specifically added by unscrupulous individuals in order to adulterate the cocaine, but specifically to increase the profit margin of cocaine. Because it looks like cocaine, it's a whole hell of a lot cheaper. They'll add it to the cocaine to sell to the user to make it seem like there's a lot more in the bag than actually is. Again, it's an off-white crystalline powder, and it's added sometimes in order to adulterate to produce a little bit more of a euphoric property. And it leads ultimately to an endarteritis obliterans. The rash is described as being ecchymotic and macular. It's as painful as that looks. It's non-tender. It's non-pruritic. And the course is self-limited, assuming that the user stops using cocaine. However, in individuals with advanced course, it can result in auto-amputation of the ears, nose, digits, and penis. There's no specific intervention necessary except for telling them to stop using cocaine. It generally resolves on its own in weeks. And if they use cocaine again during that kind of period, either during the resolution or later on, it results in a complete return of the rash. It doesn't just come a little bit, all of it comes back at once. All right, so kind of an interesting one. Case 18. We've got a 65-year-old woman who recently returned from Switzerland 3 days earlier, who now comes in with complaints of leg pain. She has a history of diabetes, hypertension, coronary artery disease, and is currently on metoprolol, metformin, and baby aspirin. Her vital signs, she has maybe a low-grade temp, that's probably orally, maybe a little hypoxic, but probably within the normal range on room air. And we see this on exam. Actually, I think you and I might have had a patient like this recently. Does anyone know what this is? All right. So what this is essentially is phlegmasia cerulea dolens. This is an extensive DVT that involves the entire deep venous system of the left leg. And phlegmasia cerulea dolens is it's a fancy way of saying painful blue edema. And the etiology is due to a clot burden in the deep venous system. This has a high likelihood of systemic embolization because the whole venous system is involved, including the proximal femoral vessels. It could be absolutely limb-threatening. You always want to check for a pulse on these patients. And just going back to the anatomy, so this is not the superficial veins that are involved. This is the deep venous system. So the femoral vein, the popliteal vein, and the tibial vein are completely occluded by clot. And this again, is a very, very dangerous condition. These are patients that get rapidly placed on anticoagulation and get admitted to the hospital. These aren't the patients that you put on Xarelto or Pradaxa and send home. These are the ones that wind up coming into the hospital because they can lose their leg as a result of it. All right. Treatment being anticoagulation. 50% of the patients, unfortunately, have an underlying malignancy, which makes them hypercoagulable and develop this clot. And they have a very high likelihood of developing gangrene and needing amputation. Any questions about that? All right, we're getting closer to that, guys. Case number 19. We've got a 24-year-old male who was running to the train and fell down onto his right shoulder. He now complains of pain to his right shoulder. He's unable to move his right shoulder. And you see this on physical exam. What does he got? All right, so let's take a look at the left shoulder. Nice and round, right? Right shoulder, we see it squaring off. Sorry about the quality of the picture. Anyone want to venture a guess what we got?
Shoulder dislocation?
Fantastic, shoulder dislocation. So this is a radiograph. So this is the most common type of shoulder dislocation that you're going to see. It is going to be an anterior shoulder dislocation. And it's kind of tough to tell in this one projection. But you see that the humeral head is directed anteriorly and inferiorly to the coracoid process. This is the same individual post-reduction with now the humeral head sitting in normal alignment along the glenoid and in relative consideration to where the coracoid process is. So just going back to some anatomy. So this is the scapula, right, that we're seeing over here. This is the clavicle. This is a acromion, coracoid process, humeral head, and then the glenoid that we're seeing over here. So same thing, scapula, clavicle, acromion, coracoid, and then humeral head, with this being the greater tuberosity, lesser tuberosity, and then the humerus. And this is just a posterior projection of it. So the most common types of shoulder dislocations are going to be anterior, and then the second most common is going to be posterior. There are other types. There is inferior and luxio erecta as well, which may be interesting to look up on your own. Anterior usually results from direct trauma. The arm is usually held in internal rotation, with the elbow being flexed, and the patient will not allow you to move that arm. Posterior almost exclusively occurs in patients that have had seizures or have had electrocutions. This actually happened to my uncle. He's a master electrician, touched the wire that he was told by his apprentice was turned off. Turns out it wasn't off, and he developed a posterior dislocation. And difference being in terms of the way how they present. Anterior dislocations, patients are internally rotated. Posterior dislocations, these patients' arms are externally rotated. All right, little video.
Free himself inside of 5 minutes. It's all over now.
Please don't have the patient reduce their own shoulders unless it's Mel Gibson and you're watching Lethal Weapon. All right. So, also, with regards to reduction, maybe tempted to kind of reduce that shoulder as soon as you see it because now you know exactly what a shoulder dislocation looks like. And I put here an asterisk. The only time you should be reducing the shoulder without obtaining imaging is only if you feel for a pulse and you don't feel a pulse. If a patient has vascular compromise as a result of traction on the brachial artery and you don't feel a pulse, absolutely pull on that shoulder. No one will fault you. The main reason why we recommend obtaining imaging first really has to do more from a med-mal perspective. If the patient results in a bank heart deformity or a Hill-Sachs deformity, after the imaging, after you've reduced the shoulder without getting imaging first, they're going to say that you were the reason why that patient developed a Hill-Sachs or a bank heart deformity. So unless the patient doesn't have a pulse, get an x-ray first, give them pain medication, and then ultimately reduce down the shoulder. So simple things that you want to do, you want to check for a pulse, you want to check for sensation going down both the anterior and lateral aspects of both the humerus and the forearm, and you want to check for hand grip. If the patient is able to squeeze your hand, their cord is intact down to T1, and they're neurologically intact, and you don't have any involvement of the brachial plexus. If you find the patient kind of in internal triage that way, with an anterior shoulder dislocation, give them a sling just to hold or prop up their arm under a couple of pillows just to keep them a little bit more comfortable until they can get the imaging done and until we can get the reduction in place. And the reduction is usually requires a combination of both local injection and procedural sedation in order to get into play. All right. So case number 20. We've got an 83-year-old woman who was walking to the bank and thought it would be a fantastic idea to go across this tremendous amount of ice. Now she's got pain to her wrist. And she comes in with this. What's going on with her? What does she got?
Colles
Right,
fracture.
it's a fantastic, exactly, a Colles fracture. And a Colles fracture is defined specifically when they're holding this in anatomical position, the distal radius is displaced dorsally. And it kind of looks like this. So this is also known as a dinner fork deformity. And that's what it looks like on x-ray. So the the distal aspect of the radius is displaced dorsally. For bonus points, does anyone know the name of the fracture when the distal radius is displaced volarly? That's a Smith's fracture. Very uncommon. The most common that we'll see is a Colles fracture. And usually we'll see it this time of year when things are raining and then it freezes over, or when people are walking on bad surfaces, they'll land on their wrist. This happens as a result of a swoosh, and the distal radius gets displaced dorsally. Again, caused by falling on an outstretched hand, and deformity is caused by dorsal displacement of the distal radius and or the ulnar bone. There's a historic classification for Colles fractures. It's called the Frickman classification. It is not uncommon to have both a radial and an ulnar fracture at the same time. It occurs in probably about 40% of all cases. All right. Move on to the next case. We've got a 36-year-old female. She has a history of seizures. She was recently started on Dilantin because Keppra and Lamictal weren't working. 24 hours ago, she developed a rash on her chest and blisters in her mouth. Her vital signs, so she's febrile, she's tachycardic, she's relatively hypotensive, she's tachypnic, right? This is not the usual 18 breaths per minute. She's got a normal O2 set. And you look at her mouth and she has this. What does she have? Oh. What was that?
Stephen Johnson.
Yeah.
Fantastic. Stephen-Johnson syndrome. So a rash that involves the oral mucosa or the conjunctiva should raise your suspicion that this patient has Stephen-Johnson syndrome. And this is what her skin looks like, this kind of desquamating rash where the skin is kind of peeling itself off. This is a life-threatening illness. Progression of involved skin can be rapid, occurring anywhere from a single day after starting Dilantin to slowly evolving over 14 days. Complications can result in sepsis, metabolic derangement, so these patients can become hyponatremic, they can become hypokalemic, they can result in respiratory failure because the mucosa is sloughed off, not just off of the tongue, but also of the respiratory mucosa, resulting in fulminant respiratory failure. And they can also develop gastrointestinal hemorrhage as the mucosa in their entire gastrointestinal tract starts to come off. Mortality is unfortunately very high. It's 50%. Etiology of Stevens-Johnson syndrome could be due to drug exposure from anticonvulsants, sulfonamide antibiotics, specifically Bactrim, quinolones, HIV medications, and this used to be more with the older generation of HIV medications, not so much now with Truvada or Kaletra, or even with certain over-the-counter medications. So very, very important to get a good history in terms of whether or not the patients have been started on any new medications, or even just to get all the medications that they may be on. Treatment is keep the patient warm. We have to treat this as if there's a burn, intubate the patient if there's airway concern, and use the Parkland formula, specifically using warmed IV fluids in order to resuscitate these patients. Currently, we don't have the capabilities of taking care of these patients here at Jersey Shore, so these patients can potentially get admitted to the ICU, but ultimately, they're going to get transferred out to a burn center for more definitive management. All right. Any questions about that? Okay. Last two cases. Yeah, was there a question, sir? Okay. Yes, not. All right. We have a 61-year-old male who comes in lethargic and minimally responsive. Patient has a history of hypertension and renal failure. Vital signs are noted to be a blood pressure of 180 over 100, heart rate 78. Patient's hypopneic. O2 sat is 91%, and the respiratory rate is only 10. Patients on lisinopril, clonidine, Renagel, and Tylenol number 3. Anyone want to venture a guess what's going on with this patient? All right, so we've got lethargy, we have hypoxia and hypopnea, and we've got the patients on, potentially a narcotic. Could this be a narcotic abuse? Sure, it's in the realm of possibility. We look at the patient and we see, how would somebody describe it? What type of pupil does this look like?
Pinpoint?
Pinpoint pupil, exactly. And so EMS often describes these patients as having pinpoint pupils, and sometimes we'll describe it as being a pinpoint pupil. So does everyone that we work with in the ER, does anyone carry with them a measuring stick or any type of device to objectively measure the size of things? Probably not, unless it's the medical students that have the pocket Snellen's chart that has like a measuring on it. But one thing that we all have rapid access to is EKG paper. Each small box is 1 millimeter. So looking back, it looks like the patient has 1 millimeter pupils. So this patient has pinpoint pupils, which are 1 millimeter and unreactive pupils bilateral. So the problem is that I think we all, conservatively get into thinking of pinpoint pupils as only being narcotic abuse. That's the only thing it could be. But the reality is there's a wide differential in things that can cause pinpoint pupils. Narcotic overdose being at the top of the list. Clonidine can also cause pinpoint pupils. Phenothiazines, organophosphate poisoning, anticholinergic eye drops, pontine hemorrhages, and strokes. Turns out this patient in this vignette actually had an overdose of clonidine and not Tylenol number 3, which was causing the patient's pinpoint pupils. So essentially, don't assume when you see pinpoint pupils that it can only be as a result of narcotics. You can start off by giving these patients, glucose if they're altered. You can give them Narcan and see if it works. But actually do a detailed neurologic exam. And you want to reassess for legitimate improvement. I can't tell you the number of times working in New York City that EMS told me that the patient had pinpoint pupils, that they gave either 2 milligrams or 4 milligrams of Narcan and said the patient got better. And then we scanned them and they have a big pontine hemorrhage. or there's something else that's going on. So actually really reassess to make sure that Narcan is making them better. All right. Any questions about that? All right. And last but not least, we've got a 45-year-old African-American male. He's got a history of hypertension. He's been hypertensive for the last 20 years. He calls EMS because he's been having difficulty swallowing. His symptoms started about an hour ago. Medications that he's currently on is Norvasc, Captopril, Plavix, and aspirin. Vital signs, essentially unremarkable. Does anyone have any concern? Just looking at this patient's brief triage complaint and medication history?
He's on a pro.
Angioedema from ACE inhibitor.
Fantastic. And that's exactly what I wanted to clue you in on. The ACE inhibitor. Patients on Captopril. Any medication that ends in IL is an ACE inhibitor. And ACE inhibitors can cause significant and profound angioedema. This is what the gentleman looked like. Significant angioedema to the lower extremity, to the lower lip. The usage of an ACE inhibitor can result in occasional angioedema. It occurs with a relatively low likelihood of incidence. The lifetime risk is anywhere between 3 to 5%. This can occur, unfortunately, after the first time of giving an ACE inhibitor, or it can occur after being on a med for 20 or 25 years. The fact that a patient's been on an ACE inhibitor for a long period of time should not dissuade you to the possibility that this may be the result of an ACE inhibitor causing these patients angioedema. It tends to be more common in African Americans, specifically Captopril has a very high likelihood of developing angioedema in African American males. And it's not recommended to start them on ACE inhibitors anymore because of the likelihood of developing angioedema. It's as high as 10% in African American males on ACE inhibitors, specifically with Captopril. This could be rapidly progressive. They can go from talking to you to needing to be intubated in a matter of minutes. The immediate intervention should include high-dose dexamethasone, starting these patients on Benadryl, just in case there's some other medication that's causing the angioedema, and starting these patients on supplemental oxygen while you're making preparations to intubate these patients. If the swelling is confined just to the lips and anterior aspect of the tongue, specifically the anterior third of the tongue, it is unlikely to progress. Again, unlikely, not impossible. If you see swelling posterior to the tongue, or if the uvula is getting enlarged, it is highly likely that this angioedema is going to progress and is going to progress very, very rapidly. You may only have one shot to intubate these patients. You want to prepare for a difficult intubation, call anesthesia stat to the bedside. I would simultaneously call surgery stat to the bedside. So that way they're making simultaneous preparations to not just intubate from above, but also cut into the neck if you can't see anything. You can't secure that airway. All right, guys. Well, that's that. Anyone have any questions?
Yeah, I have a question, Terry. Is for angioedema, is there a reason why, is dexamethasone preferred over Solumedrol, or either one could work?
Yeah, it's a really good question. So, and this is completely anecdotal. So I found that Solumedrol tends to work better for lower airway inflammatory conditions, like if somebody's coming in for COPD or asthma. And again, this is completely anecdotal. Dexamethasone tends to work better for upper airway stuff. And we tend to use it even, let's say, patients that come in with stress laryngitis. We tend to use Dex. It tends to have a more profound effect. The likelihood is that whether you give Dex or Solumedrol, it probably won't work whatsoever. And if you have a suspected or confirmed case of ACE inhibitor-induced angioedema, while you're getting the meds ready, you really should be getting the airway ready to take the patient. It is better to intubate these patients and extubate them 24 hours later. If it turns out that they don't have angioedema, then wait a couple of extra minutes or 30 minutes or something along those lines for the medication to take effect and then not be able to intubate these patients. I had a patient like this with another attending in the Bronx about 9 years ago. And unfortunately, the patient expired. I was helping him out. He wanted to wait a little bit until ENT came down. By the time ENT came down, we were unable to intubate. We tried a nasotracheal intubation and ultimately had to cut into the gentleman's neck. He was morbidly obese, could not find the midline, and ultimately we got the trach down. He had such severe anoxic encephalopathy, family made him comfort care, and he died 3 days later.
Wow.
Yeah, so this stuff goes bad really, really quickly. I really respect angioedema due to ACE inhibitors because they can go south very, very quickly. But good
I have a
question.
quick.
Yeah,
I have a quick. What about so just to go back to the herpes zoster with dendritic lesions or pseudodendritic lesions? How often do you see that? I mean, I've seen it on distribution multiple times, but do you often see the dendritic lesions?
So it could be difficult to see depending on what modality you're using. So if you're using, in my prior site, we had to use really crappy pen lights, blue pen lights, which could be very, very difficult to see dendrites. If you're using a slit lamp, you should be able to see it. And even with the width lamp, you should still be able to see dendrites. It is pretty prototypical when you see it. They may be a little bit faint, but you'll see this kind of branching pattern. And again, essentially, the presence of the Hutchinson sign should be to clue you in that there may be the presence of pseudodendrites or dendrites on the corneal epithelium.
Okay. All right. Thank you.
No worries. Good questions. Anyone else? All right. Well, I hope you guys had as much fun as I did going over this. And look forward to continuing the series. Next up, I guess we could do radiology, orthopedic lectures, and we'll coordinate with Lauren. Schedule that works for everyone, and we'll keep the series going. Thank you all for calling in tonight. Appreciate it.
Thank you.
Cool. Thank you, Harry.
It was
Thank you
awesome.
so much, guys. Have a great night.
You too.
Night.
Bye.